Hi, good morning. I'm Dr.
morning,
Ritchie.
Doctor.
I'm one of the junior doctors
Oh, right.
working on the ward today.
Okay.
Can I just double check your name before we start, sir?
Scott, yes, Henry Scott.
Henry Scott,
Yes.
okay. And can I just check your date of birth, Mr. Scott?
Yes, it's the 2nd of June 1994.
Okay, so that makes you 28, does it?
Yes.
Okay. And how would you like me to address you?
Whatever you like, I don't really mind. I would say it's okay. Henry's fine, people
Okay,
at work
Henry.
call me Henry, so...
Okay, fine. Well, call me James if you'd like.
Right.
Now, before we sort of start discussing things, is there anyone else with you today that you'd like to have in the room?
No. Well, I mean, is it... It's not bad news, is it?
Well, we've got a lot to discuss, and sometimes it can be hard to remember everything, and sometimes there's a family member that you might
No,
want.
actually, no, the wife's not here, with the kids and things,
Okay,
So,
fine. Okay. Well, there's probably a lot of questions, but just for me, before we start, could I ask what your sort of understanding of things so far is?
Well, I seem to have had some sort of a seizure, some sort of fit or other, and I was brought in, for these tests and things. I mean, having headaches over, quite the past few weeks or so, and, I've been on painkillers and things, and, I had this collapse, and, as I say, I was brought in, to find out what's going on, really. And I've had sort of various tests and things. I'm not quite sure what they're looking for, but scans and these sort of things, and the, blood tests and what have you. But I don't really know any results at all, or what's happening.
Okay, so you've had some blood tests, some scans, and no one's really told you what the results are, or
No,
it sounds like
or
really
indeed,
what the intention
really
of those
altogether what they're looking for. But well, there we are.
Okay. Well, I think what I'd like to do then, first obviously, is to tell you what the results of the tests are.
Yeah.
What this means in terms of a diagnosis for
Yes.
you. And then we'll move on to talking about how we're going to treat you. Which
Okay.
I think is
so
probably...
So you obviously found something wrong.
Yeah, we have. Now, what we have found is something that's maybe serious, and I think we do need to discuss in quite a bit of detail. So, are you happy to discuss these sort of things now?
Well, yeah. Oh, yes. I mean, you say so. Maybe serious. I mean, obviously, I want to know what it is. I mean, when you say serious, I mean, how serious? Have I, you've not found cancer or something, have you?
When somebody comes in with a seizure or a fit like you've had, you want to look for all the sorts of causes. You've had lots of blood tests, all of which have been completely normal.
Right.
Now, you've mentioned cancer.
Yeah.
And that is one of the things that we always want to look for. It's
Right.
a rare diagnosis, but if it's there, it's very important, because if you find it early, you've got a much better chance of successfully treating it.
Right. Okay.
Now, you've had the scan of your head.
Yeah. Yes.
Now, what we can see on that is that there is an abnormality.
You mean when you say an abnormality, this is your medical jargon for cancer?
I think cancer is a possibility. We've got to be upfront and honest about that.
Oh heavens, it's bad as that. I mean, it seems very sudden. I mean, I've only had these headaches for a few weeks or so, and yes, I had this sort of collapse, but surely not. And it's in the brain, is it? I mean, that's even more serious, isn't it, than maybe in the lungs or something, a brain cancer. Surely that's the worst scenario.
It's absolutely an alarming thing to hear, and I can't disagree with that.
Right.
However, what we've got to think about is in terms of treatment and prognosis, and many growths or cancers in the brain are very treatable, especially in comparison to some cancers in the lungs, like you mentioned.
I mean, let me be clear. You're saying it might be a cancer, but at the moment you're not sure whether it's a cancer. Am I right?
I think it's very likely that it is, but what we need to do is get the experts to review the scans.
Right.
Because what we don't want to do is make any life-changing treatment decisions.
No.
Based on...
I'm totally sure.
Yeah.
Yeah, I see that.
So what I'd like to do is think about your treatment in two terms: a short term
Right.
and a slightly longer term, where
Okay.
everything's been reviewed by all of the specialists and we've got all the best opinions that we can get.
This is assuming that it is a cancer.
That is
When you've
assuming that
confirmed
it
it,
is.
this is what you would be doing. If it's not, then you'll be doing something else. Okay, let me start it clear, because I'll have to explain this to the wife and everything. So let's try and get it clear in my own mind. Okay.
Okay.
Yeah.
So in the short term, you mentioned that you've been having headaches,
Yes.
and that obviously the seizure that brought you into hospital. Now, one of the reasons that these may have been happening is that when there is a growth in the brain, it can cause a little bit of inflammation and swelling around it. So
Okay.
what we would do in the very first instance is give you some medicines that we would call steroids, which will help reduce that swelling and hopefully reduce your headaches
Right.
and reduce your chance of having any more seizures.
But that is not curing the cancer, is it?
No.
No.
And that's why this is
No.
a short-term treatment.
Okay.
So
okay.
over the next day or so, what we're aiming to do is to start treating your symptoms and get you feeling better in
Right.
yourself.
Right.
In the longer term,
Yeah.
after we've reviewed the scans with the specialists and discussed it with them, we need to think about what the best treatment was to be.
Yes.
Now, that would depend, firstly, if it is proven to be cancer.
Right.
As you've said, if it is or it isn't, then the treatments would be different.
Yes.
If it is shown to be a cancer, then the treatment would depend on the type of cancer that it is. Sometimes cancers can be treated with drug therapy. That's what
Right.
they call chemotherapy. Have you heard of any of this before?
Well, obviously, you heard of chemotherapy. Christies and people like that do that, don't they? And
Indeed.
what have you? Yes.
Yeah. And if that was to be part of your treatment, then that would be guided by specialists there. Other treatment options would include X-ray therapy, so that's called radiotherapy, and again, that's something that the cancer specialists at the Christie lead on.
These can all have some quite bad side effects, can't they? I believe. Is that right?
The potential for side effects is there, and there's no getting away from that. What we
Right.
would have to do is work out, firstly, what the best treatment was, because ultimately what we want to do is cure you. And then what we'd have to do is say, well, this is what we think the best treatment is, but obviously this is a decision not for us to make by ourselves, but for you and family,
Right.
if you wish, to be involved in. So I think
Yeah.
when we've decided what the best treatment is, then it's really for us to say to you, this is what we would advise, these are the benefits potentially, and these are the potential side effects. And then we can discuss this and you can come to a decision in your own mind as to what you think would be the best for you.
So you're saying actually the final decision really rests with me, in a sense.
As much as you want it to, yes.
Right.
It's our job to offer you what is best, offer you options. We can provide guidance, but any decisions about treatment are yours to make.
I mean, you're saying about this cancer, and you said there were different sorts of cancer and things. I mean, given my age at 28, I mean, where would this come from? You know, I mean, you can sort of imagine it as you get older. You're presumably more liable to catch these things, but you know, early on, I mean, is it hereditary or is it something you catch in a way? I mean, are the children going to be affected? I mean,
Okay, it's a very honest question. It's a very hard question to answer. This isn't something that you've caught in the way that you catch a cough or a cold.
No.
This isn't something that's transmitted person to person. The exact cause of it, I think, is very difficult to explain. There may be an underlying risk just in the way that you're built. We look different. We've got different coloured hair. We've got different coloured eyes.
so
Some of us have a different level of risk for developing cancer.
there could therefore the children could be at some risk then on that argument that you've said, because they will obviously have similarities to me, won't they?
That's a fair interpretation of it. Now, this doesn't mean that they are definitely going to get cancer by
No.
any stretch of the imagination. It may mean that they're at increased risk. How old
Yeah.
are your children?
At the moment, just young at the moment. There's a 4-year-old and a 6-year-old.
Okay. I mean, I think at this point in time, my main focus is on you and getting you well. I believe if this is a cancer, we've got a very good chance of treating it, and I think that's what we want to focus on right now.
Yes, yes.
I understand your concerns about your family, and I can truly empathise with that, but I think that is something for much further down the line, and our focus right now, as much as we can, should be on you. I understand you're worried about your family, but what I want to do is deal with the problem we've got right now, and that's getting you better. Back home with
can
them.
Headaches and things be an early sign, or presumably it has in my case?
It's very difficult to say. There's hundreds of people who will have a headache who will have absolutely
Oh
nothing
yes. I
wrong with
mean,
them.
I've not really thought about headaches until, in that sort of way until, today, till now.
Yeah. Certainly, I don't think having had the headaches for a week, a month, or anything like that has changed what's happened here.
No.
So what we do is deal with the information that we've got now.
Yeah.
What I want to do in the first instance, and I'm recapping a little bit, is just to start trying to treat those symptoms. We've obviously got you on some painkillers,
Yes.
but I would like to start these steroid medicines,
Right.
if that's okay today.
Yes,
Try and reduce the
whatever you
swelling,
think's
help your
appropriate.
headaches.
Yeah.
And when we have discussed with all of the specialists your scans, then I think what's best is if we meet again, we could then discuss everybody's opinion, and we can start discussing what the best, more long-term treatment option is to get you back home and well.
Yeah. If it wasn't cancer, I mean, you said you think it's likely, but, I'm hoping it isn't, obviously, but what else could it be? I mean...
There are genuinely a range of options. Sometimes people can have small infections. Sometimes we can get slightly misleading appearances on a scan, which may just be a variation of normal. Everybody's a bit different.
Yeah.
I would stress that what I'd like to do is work on the assumption that we are dealing with a cancer. That is, as you've said, very much the worst case scenario. And I think that's something that we should prepare ourselves for.
Yes.
And what I don't want to do is give you the impression that I think that's unlikely.
Yeah.
So what the most important thing is in terms of the diagnosis is getting the expert's view. What the most important thing in terms of your care is right now is getting you started on some symptom controlling treatment.
Yeah, I mean, it's not... I mean, cancer, as I say... I mean, the wife's going to ask this, and I'm thinking it probably... I mean, it's not life-threatening, is it?
I don't know, is the honest answer. Many cancers that will affect young people are very treatable. However, some may not be. So this is why the expert opinion is the most important next step.
Yes, of course, yes. Well, yes.
Time if we stop there.
Thank you very much.
Okay, thank you very much, Dr. Ritchie. Would you like to just briefly summarise for me the salient points of the conversation you've just had?
Okay, so that was a consultation with Mr. Scott, who was a young gentleman who presented with signs and symptoms consistent with cerebral pathology. He's been investigated for causes of his seizure and headaches, and changes on his CT consistent with a malignancy have been identified. What we've been discussing in that consultation was the risk of the diagnosis being cancer and treatment options in the shorter and longer term. I think the most important points that we discussed were initially symptom control and then long-term management planning.
Mm-hmm. Now, was this a diagnosis he was expecting, or...?
No. I think it was quite clear that he was surprised. He did raise it as a possibility, but I think that was a man discussing something he expected reassurance that it wasn't, rather than a genuine expectation that it was that.
And how did you... He asked at one point, so is it cancer? So how did you address that?
Well, I think what we had to acknowledge was the diagnostic uncertainty. What we have is imaging suggestive of an astrocytoma, but there's no confirmed diagnosis. There's been no neuroradiology opinion or oncology opinion. What I tried to do in that consultation was acknowledge the fact that this was the most likely diagnosis and prepare him for that, but accept that there is an element of uncertainty.
Mm-hmm. And I mean, I thought you did many things well there. I think the introduction of yourself was good, and you clarified that you've got the right patient and got some unique identifiers about that. The use of the word abnormality on the scan, and I think that the patient had to pick you up on that. Is there any way you could have described that better?
I think there are lots of phrases that you could use. In this scenario, he'd already introduced the word cancer, and what I wanted to say was that his scan was, as I use the word, abnormal. I did not want to say, yes, this was cancer, because there was an element of diagnostic uncertainty. And by introducing it in those terms, I wanted to phrase it that there could be a possible differential diagnosis. It may have been appropriate to say, we've had your scans and there is a possibility that this is cancer. However, I would see that as the same way of maybe achieving a different.
And I think at some point we touched on the issue that he was concerned about his children inheriting that this is an illness. Is that likely with all of the differentials you're thinking about? Is it likely that they're going to be suffering from this at some point?
I think ultimately it's very unlikely that his children are going to suffer from a malignancy. However, there is no clear-cut cause on the assumption that this is cancer, for the reason he's got a malignancy. I think a family history would be considered a risk factor. So while they would be at a relatively increased risk compared to their peers, that's an increase of what is really a small risk.
So we could be quite reassuring there and say it's unlikely. Good. I thought there were some good points in this that I thought were excellent. The asking if there was anyone with the patient to share with, in this setting, make sure that someone else who might perhaps understand taking a bit more of what's being said. You showed good empathy throughout. We got a clear plan of what was going to happen next, and I think the patient was sure about that. And you checked that he understood what was going on and what was happening next. Is there anything you would have done differently?
I think perhaps it would be better handled to give more of a warning shot. I certainly went in with a plan that I wanted to raise the idea that this may not be good news, but I was preempted to that by the patient asking if this was cancer. So I think at that point perhaps it would have been appropriate to immediately tackle that issue. But I wanted to ensure the sort of foundation of knowledge that he had, and to try and get an idea of why he may be concerned about that. So would I have changed it? Probably I would have handled that in a more direct manner next time. Good,
thank you. So this scenario is clearly a Breaking Bad scenario, Breaking Bad news, sorry. And the key things here are universal across all similar scenarios. So checking you've got the right person, checking you've got the right information about that person, ideally giving them some sort of warning shot that you're about to give them bad news, checking that they don't want someone else to be with them, which in the PACES scenario there won't be anyone else available, and also checking if they want to actually know the information that you have. And I thought Dr. Ritchie handled that all very well, and the patient was left with a clear understanding of what was going on, delivered in a sensitive manner, and a clear plan of what was going to happen next.